Good evening, everyone. Thank you all for joining us to learn more about OCT technology and how you can use it to improve patient care while also generating a positive return on investment with this instrument. My name is Christina Kirby, and I'm the Marketing Director at OptoView. We're thrilled to have Dr. Mila Brujic with us this evening to present, and I am certain that you're going to leave this webinar being more confident in your ability to use this technology in your practice. And just a note before we hand it over to Dr. Brujic, if you have questions during the presentation, you can type them into the Q&A box on your screen, and we'll stop at the end to have Dr. Brujic answer those questions. And with that, I will hand it over to Dr. Brujic.
Thank you, Christina, and good evening, everybody, and thanks for joining us on the webinar. This is going to be an interesting one. I hope it's an information-filled one. I hope that for those of you who currently are OCT users, gather a few clinical pearls from this discussion. And I hope that those of you who are kind of on a fence or where I was prior to OCT implementation into the practice, just kind of get a better idea of what the OCT can actually offer your practice. It's interesting when you actually look at optometry and see how we've changed and evolved as a profession, because the basis of our business still lies significantly in the exams and the glasses and the contact lenses that we prescribe and that we fit. But what's remarkable is that there's this whole new graph, so to speak, or there's this whole new segment of optometry which encompasses general wellness, health care, and medical eye care. I'm always one that really emphasizes this portion of optometry when we're discussing this type of topic. I certainly don't want you to think that we're actually getting rid of the other side of things. I think it's all important, and I think it actually adds to the full scope model of it. And that's actually where OCT technology really brings us. It brings us really kind of to the future in optometry, and it literally offers us the ability to, again, manage our patients more holistically from a wellness perspective and from a medical perspective or an ocular medical perspective. Now, whenever we're looking at technology, there's really three big things that I ask myself before we implement anything into our practices. The first question is what's it actually measuring? The second question is, will it help me make better decisions for managing these patients or the individuals that we're caring for? And then the third, and maybe one of the most important, is, does it make sense? If I know what it's measuring and I know that it's going to help me make better clinical decisions, but from a dollars and cents perspective, it's not something that's feasibly brought into the practice, it's just not something that's going to make it into the office. So we're hopefully going to answer all three of these questions, and then like Christina said, we're going to stop at about 10 to 9 and answer any questions that anybody has throughout the discussion. So the first thing and the most important thing is what it's measuring. Now, we've all been to OCT courses, and we jump right into the meat of the discussion when we're talking about OCT and how it's utilized in the practice. But I think it's important to take a step back and really understand what we're looking at here, because it is such complicated information, yet it's presented so simply when we're looking at the scans. See, all of us had to learn the layers of the retina for our board exam. But what's remarkable is the fact that we're utilizing this information at this point on a daily basis with our OCT and our OCT technology. It's important to understand that we can see every single layer of the retina with these scans. And again, to recalibrate everybody before we move forward with the discussion, because again, before we can truly appreciate the abnormal, we need to understand the normal and what it actually looks like. So these are all conveniently labeled on your screen here so that you can actually see what's being looked at. And number one is the internal limiting membrane. Now, in a normal individual, the internal limiting membrane is invisible. But what you'll see is in pathological or diseased eyes, this is visible. And that's actually one of the things that we can track with this technology. The second layer, or layer number 2, is the nerve fiber layer. This is actually one that we've been looking at for years with our glaucoma management. But we're going to find out how this layer and the layer just outside of this layer, which is number 3, the ganglion cell layer, and layer 4, which is the inner plexiform layer, are actually going to be important markers with our glaucoma patients, and some new markers that I'm actually going to identify this evening for you so that you can actually see how it'll even help you distinguish those normals from abnormals, and maybe those potential individuals who will actually benefit from more aggressive treatment as well. But again, you're looking at one cell. Number 3 is the body of the ganglion cell. Number 2 represents the axons of the ganglion cell. And the number 4 actually represents the dendrites of the ganglion cell that's actually communicating with the internuclear layer. The internuclear layer is number 5. And then where it communicates with the photoreceptor cells is number 6. Number 6 is the outer plexiform layer. So again, plexiform just simply means those cells are communicating with other cells. Now, here's where it really gets interesting again. Number 7 is actually the cell bodies of the photoreceptor cells, the actual rods and cones in our eyes. And what you can see is a larger, darker area that consumes much of the OCT cross-section running all the way across it. Number 8 actually describes the photoreceptor boundary, or the inner segment, outer segment boundary of the photoreceptor cells. And just below that is actually the outer segment of the photoreceptor cells. Number 9 represents the retinal pigmented epithelium. Now, when you look at the outer segment of the photoreceptor cells, just below number 8, and the RPE, which is number 9, you see a small, thin, dark line. That's actually the separation, or where the photoreceptor cell outer segments are actually interacting with the RPE. And then number 10 is the shadow that's actually cast through the retina via a blood vessel that's kind of superficial in the retina. Other things that you kind of need to keep in mind is that if you ever see anything that's a dark space or a dark circle in the body of the OCT, that's either a cystic space or something that's literally pulling the retina and you actually just simply have an air pocket there, or it's some type of fluid, some type of either serum or blood that's present in the retina. And we're going to talk more specifically about that when we start looking at specific cases. So we've answered the first question, what are we really measuring with the OCT? The second question is, again, will it help me better manage my patients? And I thought the best way to actually answer this question was take you through what I consider probably the 10 most monumental things that the OCT actually measures and the OptoView OCT measures. And we're going to talk about some of the specifics on that. But more importantly, how it's actually changed the way I'm managing patients because of the OCT scans that I'm actually acquiring and the information that I'm determining from it. The first is a perspective change. It's wellness. Now, wellness is kind of an interesting concept because healthcare just in general seems to be one that's, relatively speaking, somewhat reactive. Somebody walks into our offices, and when they walk into our office, they come in usually presenting with a problem. And when they present with a problem, we normally look at that problem and we try and fix that problem. Well, wellness is simply, again, another way or a different way to change or to perceive that. Wellness is in my mind, more proactive approach to taking care of patients. So what does this look like in the optometry space? Well, it means detecting and catching disease earlier. It means educating patients on risk factors if certain risk factors are present and how they can mitigate the chances of those risk factors actually leading to disease. What's interesting with the eye view and the eye scan is that with this technology, you can actually run wellness scans on your patients. And what's remarkable is the ease to which the interpretation of these scans actually is. This is a study that Jerry Sherman actually published, and essentially what he was doing was comparing his ability to detect normal versus abnormal, so the kind of the professional's perspective, the expert's perspective, so to speak, and comparing that against the novice, the person who really doesn't have a lot of experience with OCT. And after a short course on how to read the wellness scans, it was almost as sensitive and as specific as Dr. Sherman was in gathering this data and differentiating between the normals versus the abnormals in almost every case. And these are just some real-world examples of some of the things that you'll be surprised at if you implement the wellness scans into your practice. So this is a patient who came in complaining about some decreased visual acuity in the right eye, and that's what you're looking at here. Now the top left-hand scan is a horizontal cross through the retina, and the top right scan is a vertical cross section directly through the fovea. And what you can see just superior to the fovea, so on the right-hand scan, just to the right-hand side of the actual fovea, which is the dip in the center of that scan, you see two small little black areas in the body of the OCT scan. This is abnormal. This is either fluid or some type of cystic space that's created in the retina, and it just simply needs to be managed or examined further. This patient was actually referred out to retina and was actually injected with intravitreal shots. This is another example of a patient who actually came into the practice and complained about decreased vision. And upon physical inspection or examination, it was a little difficult to actually determine what was causing the decreased vision. But when you look at the scans, in particular the retinal cross-sectional scans, and in particular looking at the vertical scans, so the one on the right-hand side or the upper right-hand side, you can see the top layer of the retina, or the internal limiting membrane, just simply being visible, and the top portion or the inner surface of the retina being almost wrinkled. What you're actually looking at here is something called an epiretinal membrane, which is literally a contraction of the internal limiting membrane over the surface of the retina. And when that occurs, it actually causes some level of visual disturbance. When you actually look at something called an en face view, and when you look at the upper left-hand scan, you can actually see this. It's almost like you're looking at the surface of the retina, again, looking down at it. And you can see how there's a crinkling appearance, almost like you have cellophane on the surface of the retina and you're actually pulling it in that upper right corner. These are things that you just miss. It's just difficult to see these sometimes on clinical inspection with these individuals. So we're fortunate that we have the ability to run these wellness scans on individuals and catch some of these things prior to even detecting them on the physical examination. Now, there are a number of other things that we actually have access to when it comes to OCT technology. One of the ones that has literally changed in terms of a paradigm shift and really what the new standard of care is managing patients who are currently taking Plaquenil. Relatively recently, the American Academy of Ophthalmology actually updated their criteria for the standard Plaquenil exam. And what you realize here is they've now included OCT scans in their requirements or in the standard of care for these individuals or these patients. Now, they do specify high definition or spectral domain or Fourier domain OCT, which is really the level or the technology or the generation at which the eye views at. And when you look at this scan, for example, from an untrained perspective, it looks relatively speaking normal. And I want you to just take a moment to look at this scan to determine whether or not you see anything that's abnormal in this patient taking Plaquenil. Now what I'm going to do is I'm going to highlight the area that's abnormal by just simply drawing a blue box around it. Now what you can see after I've actually brought it to your attention is that when you're looking at the outer segment of the photoreceptor cells, or essentially the photoreceptor integrity line, it actually is absent in the area that's in the blue box. Again, compare the area to the left and to the right of the blue box where you can actually see the RPE, which is the most outer portion of the measurement. You can actually see the in or the outer segment of the photoreceptor cells. But again, then when you enter into that blue box, it's almost absent. It's like somebody took an eraser and actually tried to rub it out. So those are things where you'll actually catch early signs of Plaquenil toxicity prior to fundus photos, prior to even sometimes visual field inspection with the 10-2. So this has changed the way we're managing our Plaquenil patients. Another way that we've changed the way we're managing certain individuals is those that we're identifying as having epiretinal membranes. And much of the reason for that is because they're very, very difficult to detect without OCT technology. Now again, this is a fundus photo of somebody with a epiretinal membrane. And as you can see here, after I've highlighted it, and you know that it's an epiretinal membrane because it's coming after the title slide that's entitled Epiretinal Membrane, you can actually get a sense and see it. You can see that it's slightly cloudy around the fovea, and you can even see the fovea almost has kind of a cherry red spot around it. But these are difficult to tell. And what we've realized is there's just more epiretinal membranes in our practices than we ever thought there was. Now, when we overlay the scan of the OCT, the en-face view, or essentially the surface view, you can actually see the crinkling that's occurring here on the surface of the retina and the irregularity that's being caused by that. Now, this is actually the cool thing about the OCT is you can simultaneously view the en-face view, which is that top left quadrant view. So you can see the wrinkling that's occurring on the surface of the retina, but you can also simultaneously see the cross-sectional view right at that same spot. And you can see the green line actually going through the upper left-hand picture, and that's exactly where that retinal cross-section is occurring. And that's the scan that you're looking at in the bottom left-hand portion of the slide. And again, you can see just the irregularity that exists in the internal limiting membrane that's present there. See, these patients were in our practice, but they were simply being undetected. And you can go through any portion of the retina, and again, you're just seeing another scan, a vertical scan through that same patient, but you can go through any scan in the macula, and you can determine what's causing the decrease in best corrected vision. Again, these are individuals that we sometimes blame early cataracts for reduced best corrected visual acuity or other issues that we're trying to explain this with. But with an OCT scan, this really adds a certain level of definity to the diagnosis and why that patient's visual acuity is reduced. Normally for epiretinal membranes, we're not really referring for treatment unless it's at a 20/40 or worse, and that's when we're starting to have those more serious conversations with those individuals or those patients about a true epiretinal membrane peel. So vitreomacular traction, we are certainly managing these individuals and patients different because, again, now we're seeing what's happening and going on in the retina. Again, I challenge you when you look at this picture in particular, best corrected visual acuity of 20/30, and we're not sure why, and we're looking at the retina. And again, this is actually an unfair advantage that I'm even giving you as the viewer because you're looking at a fundus photo, which isn't really what we're looking at these individuals at when we're viewing them in our offices and in our clinics. But when we run an OCT scan, we see very, very quickly what's going on, and it becomes very, very telling. So again, when you look at the top left-hand view, you can actually see the scanning laser ophthalmoscope view, and you can actually see the green line showing exactly the portion of the retina where we're doing the cross-section through. And you can scan that up and down through that scan, so you can get through any portion of that retina that you want to. When you look just below that, you can actually see the vitreomacular traction and adhesion that's actually present in the foveal area. And you can see the small tugging that's occurring and why that individual has a reduction in their best corrected visual acuity. And again, simply another view of that same patient or that same individual, just looking at it the color scan as opposed to the kind of the grayscale scan. And again, you can see in that upper view exactly where those two attachment points are of the vitreous to the underlying retina where it's actually pulling that individual's macula. This is another example of an individual who came into the office saying, you know, my vision's just a little bit fuzzy in two little spots in my macula. They're actually a monovision contact lens wearer with a reduction in their vision up close. And when you actually run the OCT scans, you can see exactly why this happened. This patient doesn't have a macular hole. They have what's referred to as a lamellar macular hole, or essentially only affecting the upper portions of the retinal tissue. And you can see that very, very clearly here, just because of the fact that there's just some missing retinal tissue superior to the photoreceptor cells on both the right and left-hand side of the actual fovea. So these individuals, again, were going undetected, or they had decreased best corrected visual acuity with an unexplained reason or a questionable reason. We're adding definity to the diagnosis, and we're able to manage and monitor these patients and follow them over time to see if they actually break apart from the retina and if that vitreous actually comes apart. We now have other treatment options that are available as well, Jetria or acroplasmin, which can actually degrade the connection between the vitreous and the macular or the retinal tissue as well too. But again, we're now able to really discuss this at another level with our individuals. So how else has it changed the paradigm or how we're actually practicing? Well, one of the ones that I thought I was going to be using the instrument for the least amount, which is actually occupied about 50% of the posterior segments, is for those individuals with macular degeneration. Why? Why are we scanning individuals who have macular degeneration with an OCT? Well, this patient right here, this is a picture of their right eye. They have 20/60 best corrected vision in the right eye, which is this eye, and 20/40 in their left eye. And we're looking at the fundus photos. We're looking at the physical examination. We're inspecting or physically inspecting the fundus, and we're unsure why that's happening or why there's a discrepancy in the vision. But it's remarkably telling when you actually look at the OCT scans. Again, remember that even though I identify these conditions and these retinal states as separate items, they're oftentimes occurring in sync with one another, or there may be multiple conditions that we're actually managing or monitoring, like this individual. So when you look at that top left scan, again, you can see the en-face view, or again, what's really referred to as the surface view of that retina. So you're really getting a good detailed view of the internal limiting membrane. Now, when you look at the scan just below that, it's actually the cross-sectional scan right at where that green line is. And you can see two things. You can actually see the irregularity in the surface of the retina that's occurring because of that epiretinal membrane or macular pucker, which again are essentially synonymous terms. But you can also see the drusen that's present towards the bottom of the retina. When you just simply take a higher mag view of those retinal cross-sectional views, you can see exactly where the drusen is and where the epiretinal membrane is, and you can follow these individuals over time. So we've explained the decrease in best corrected vision in one eye versus the other eye. But why else would we scan our macular degeneration patients on a regular basis, depending on levels of risk? It's usually every year, every 6 months, or for some individuals even more so than that. So why would we scan this patient right here, 20/30 best corrected visual acuity with some larger drusen that's actually present? Well, what we're trying to do in these types of individuals is we're trying to rule out any type of neovascular membranes or any type of leakage that's actually occurring. Remember what I said earlier, leakage or any type of blood in the retina actually appears as these dark or large pockets of dark areas. Any type of interstitial spaces or any type of intraretinal cysts that are occurring are these large dark pockets. When you look at the bottom of the retina, you can actually see the drusen, and you can see how they form almost a lumpy pattern to the bottom portion of the retina. And you can see how there's a solidity almost, or a lack of kind of this dark that you sometimes will see with leaking. How does this differ? How does this type of drusen differ from the individual who actually does have a leak? Well, here are two examples of some retinal leaks. So on the top picture, what you see a large sub-RPE leak, and on the bottom portion or the bottom picture, you actually see a leak that's actually present in between the RPE and the rest of the retina, or an intraretinal leak. And that's how they differ. So again, you're looking at large areas where there's potentially some type of leakage or something that's actually occurring, and that's what we want to try and avoid. It's one of the reasons why we're scanning these individuals. We're looking for areas where there may be early signs of leaking, because we know if there is any type of early leaking or early hemorrhages, the sooner that we get them to retina for treatment, the better their chances are of preserving their vision. So again, prior to OCT technology, we're simply doing a physical inspection of the eyes. Now with the advent of Fourier domain or spectral domain OCT technology, we're literally with our eye view scanning these individuals essentially every time we're seeing them, again, so that we're ruling out any type of leaking that's present in the retina and ultimately improving patient outcomes. So again, we've talked about a few macular conditions, but there are other things that we watch and monitor with these individuals that I personally wouldn't have felt comfortable with prior to incorporating this technology in our practice. One in particular is those individuals who have had a history of retinal detachment surgery, who have this almost kind of this vitreous coalescing in front of the retina, like you can see here on the right-hand side of this individual. Now, when you take OCT scans on this individual, you actually see the irregularity that exists and the epiretinal membrane that exists as well too. And these are conditions that we would have felt uncomfortable managing prior to OCT, just because again we don't know what's happening or occurring to the retina. But barring similar appearances over time when we scan these patients over time, because that's what we're really doing is we're watching these individuals, and barring any changes in visual acuity, we're managing these patients in our offices, and then what we're simply doing is referring them to retina when need be, or when there is a change in the appearance of the retina, or when there is a change in vision. Whereas prior to OCT technology, we were really looking at referrals to retina when there was a change in visual acuity that was unexplained. Other conditions that you'll actually see in the practice and that you'll start managing, because again, retinologists will essentially give you the not necessarily the freedom, but you'll feel comfortable monitoring these. I still remember 3 years ago, the day that we had we received our eye view in our practice, and a local retinologist was actually just starting his practice locally, and he walked into the practice, and he said, "Oh, you guys have Fourier domain or spectral domain OCT?" So that's great. I said, "Yeah." He said, "What system did you go with?" I said, "We went with the eye view by OptoView." He said, "Great system. You're going to love it." He says, "I'm glad I know that too, because now I know what you're comfortable managing, because you're going to get better views of the retina and you'll feel comfortable managing this in-house." So again, for these individuals with things like vitelliform dystrophy, we can just simply watch these individuals and manage them in the office so that, again, they don't have to go to retinology if they don't need to, again, barring consistent vision and consistent appearance of the macula over time. Again, that's one of the key things that we look at with all of these scans is the repeatability of the scans and determining how stable or unstable these individuals are. Now, here's where we get to kind of the interesting part of the discussion, because when we first purchased our first OptoView OCT about 7-8 years ago, we thought that 80 to 90% of our scans would be glaucoma scans, and about 10 to 20% would be some level of macula scans. Again, we were surprised at how much macula, first and foremost, we were managing with the OCT and just simply managing differently and better. And I hope you got a sense of that, kind of walking through some of those cases that I showed you. But this is kind of interesting when we look at glaucoma and we look at how the paradigm has simply evolved. So we've been managing and we've been monitoring retinal nerve fiber layer thickness for years. We did it with the Stratus OCT. We did it with the GDX. We've been doing it for years. And even with early generation spectral domain OCTs and with our current generation of spectral domain OCTs, this has become a staple of what we're actually looking at with our glaucoma patients. And it simply represents the nerve fiber layer thickness, which is essentially the axons from the ganglion cells coming back to the optic nerve and heading back to the brain. But here's where we've really evolved. With the ability of this technology to actually take the information that we've acquired and now analyze it in ways that are so highly sophisticated that it can virtually predict the future for the individuals that we're caring for. This is where it's really advanced. One of the things, or one of the software packages that the iView has access to is something called trend analysis. And here's what this does. With a minimum of 3 scans, so that's really what you need to start forming or determining whether or not there are trends. With a minimum of 3 scans, you can actually start determining whether or not that patient is staying stable or the patient is declining or decreasing or essentially getting worse. And you can look at this through the TSNIT pattern, or essentially the nerve fiber layer thickness around the optic nerve, which is what you see on the bottom portion. But you can also see that with the ganglion cell complex, which I'm not going to talk a lot about right now because that's actually going to be our next topic of discussion. But when you actually look at the graph on the left-hand side, that's the average retinal nerve fiber layer thickness. All of those blue points represent the nerve fiber layer thickness that we've measured in office. And then after that, you're actually looking at the trend line, or what the software is expecting will happen with this individual's retinal nerve fiber layer thickness over time, barring no changes in treatment, and essentially predicting that everything will go as is right now. And you can always also see that trend line on the GCC, or the ganglion cell complex, on the lower right-hand portion of the slide as well too. So what you can see in this individual is we need to really think or consider changing therapies if we haven't yet. So when we look at glaucoma, where we've really evolved and kind of added this new metric, this new thing to consider with our glaucoma management patients, is this metric called GCC, or ganglion cell complex. Here's really what the GCC, or ganglion cell complex is. It's a measurement highlighted here by this central circle in the center of this pictorial, or this essentially this picture representing the nerve fiber layer spreading over the surface of the retina. And what it's doing is it's measuring the thickness of the nerve fiber layer, the ganglion cell, and the inner plexiform layer, which is essentially where the dendrites of the ganglion cell communicate with the with the inner nuclear layer. So you're essentially looking at the thickness of that ganglion cell, and you're determining whether or not there are changes in thickness to that area over time. And here's what the eye view actually does when it scans that area. It takes one horizontal cross-sectional scan, but then it takes a number of vertical scans. And we know that vertical scans are valuable to us as when we manage glaucoma, because we're looking for symmetry, or even a different way to describe it, asymmetry. That's really what we're looking for in the glaucoma patient. We're looking for, are there differences between the superior and inferior portion of that nerve? And measuring these vertical scans gives us essentially the ability to do that. So this is specific, or this is the exact area that's being measured. Again, the ganglion cell complex is comprised of the nerve fiber layer, the ganglion cell layer, and the inner plexiform layer. And again, it's that inner layer of the retina. And when we actually look at what these scans look like, they're always represented in this circle, so to speak. And this is a normal scan. This is actually a ganglion cell complex of myself. So what you can see on the top portion is the thickness map, and you can see this donut appearance that actually appears around the fovea. But even more importantly is the significance map that's located just below that. The significance map tells me, based on my age and based on the scan that they took, am I in the normal range, or am I outside what the software would expect to be the normal range? And when you see what this looks like, when you look at both scans on one printout, you can actually see the right eye on the left-hand side and the left eye on the right-hand side. And you can already see that there's, in the top scan, there's not that healthy donut appearance around the fovea. And when you take the next picture down where you're looking at the deviation map, you can actually see where the decreased thickness actually is. And then when you look at the significance map, which really shows us where the software thinks this patient is outside of the normal range, you can see significant decrease in in structure inferior of that fovea. There certainly are some changes superiorly, but there's definitely more changes inferiorly that are occurring, that are corresponding to that decreased thickness that we actually see in the upper two scans. So what does this do to how we actually manage our glaucoma patients? Well, it's actually made me challenge myself and rethink the 10-2, which is essentially this high definition view of the central 10 degrees of the visual field and that functionality within the central 10 degrees of that visual field. So what you see here on the left-hand side are 24-2 representations. What you see in the middle are 10-2 representations, the top being one patient, the bottom being another patient. And then what you're actually seeing on the right-hand side is the ganglion cell complex for both of those individuals. And what you're seeing is the high structural and functional relationship that exists between these individuals when you look at them on that central 10-2 scan. One of the things that I would take away from this as well, too, is if you're running a 24-2 and if you even see one area of decreased sensitivity in the 24-2 in that central 10 degrees, run the 10-2, because you may be looking at a situation where it doesn't seem like a large defect, but as you can see in the bottom case, you see kind of this small area where you see just a slight decrease in functionality on the 24-2, but when you rerun it on a 10-2, you see how visually devastating that small, or what appears to be a small, functional defect is in that patient's vision or that patient's sight. And what's remarkable about the ganglion cell complex is it continues to be supported through both clinical validation, but also research as well, too. And that's actually one of the things I wanted to share with you guys right now, because there was a study last year at the American Glaucoma Society that looked at the importance of metrics that we rarely looked at on our ganglion cell complex scans. So again, this is a typical ganglion cell complex scan. But on the right-hand side, for those of you that are current OptoView users, and even for those of you that are purchasing or are going to be purchasing an OptoView by OCT, These right-hand side metrics, again, are sometimes difficult to really embrace, to really understand, and put some logic to. How do we actually use those numbers? Well, I'm going to share with you how we've done that. And since we've seen the data, we've literally changed the way we're managing certain glaucoma patients. So here are the two metrics, or the two numbers, that I want you to pay attention to. It's FLV percent and GLV percent. That actually stands for focal loss volume and global loss volume. Focal loss volume is described on this side, and it detects localized thinning using a pattern deviation map to correct for overall absolute changes, much like corrected pattern standard deviation features in visual fields. So what's the translation of that? It means the more irregular the patterns are in your ganglion cell complex, the more likely you are to be outside of the normal range on your FLV measurements, or focal loss volume measurements. The great thing about it is you don't have to memorize numbers that are in the normal range or outside of the normal range. The software actually does it for you, and we're going to find out why that's important in just a second. But if the software thinks it's marginally abnormal, it'll actually color code it yellow. If the software thinks it's definitely outside of the normal range, it's going to color code it red for you. So what's GLV? GLV assesses the extent of overall uniform depression of the ganglion cell complex thickness. GLV equates to generalized erosion or flattening of the hill of vision if we're thinking about that visual field analogy. What does that mean? Well, it means that some individuals may just have a slightly thinner overall ganglion cell complex. And in those individuals, they would simply have a GLV that would be outside of the normal range. But they may not necessarily have a focal loss volume that's outside of the normal range. So keep that in mind when you're looking at that data. So what does it actually mean is more important. I'm actually going to skip this slide because I think the next two graphs are most telling. And these are the things that you need to remember. So when you're looking at FLV, or focal loss volume, this was the study setup. They actually looked at individuals and they measured their FLV prior to entering the study. And they recruited glaucoma suspects, those individuals without glaucoma, and they included patients who were diagnosed with glaucoma. So those glaucoma suspects is what we're looking at now. And they literally put them in two categories. Those individuals who had a ganglion cell complex with an FLV that was either borderline or outside of the normal range. And then they put the normals, or those individuals who had an FLV that was in the normal range, in another category. And then what they did was they simply followed these individuals over a 6-year time period. And what was remarkable was, in that 6-year time period, those individuals with an FLV outside of the normal range, or borderline, had a 41% chance of transitioning into glaucoma, or essentially visual field loss secondary to glaucomatous changes. Those individuals who had a normal FLV, or an FLV within the normal range, only 10% of those individuals actually progressed to developing glaucoma. This number is important. And it's even important with our current glaucoma individuals. So those patients that we've diagnosed with glaucoma, we're managing and we're monitoring them. Those individuals with an FLV that's in the normal range versus those individuals that have an FLV outside of the normal range have to be managed and monitored differently. Specifically, those with FLV that's outside of the normal range, we literally need to make sure that we're being remarkably more aggressive with these individuals because, again, they have a 60% chance versus a 30% chance over a 6-year time period of developing or progressing their level of visual field changes that are occurring. So keep that in mind, current OptoView users, and for those that are actually purchasing the technology, make sure you keep FLV in mind because it is an important metric. And although the numbers on the right-hand side can be somewhat intimidating, that number in particular is remarkably important to keep in mind. So again, we're changing the paradigm. We're simply managing these individuals differently based on the information and the knowledge that we're actually acquiring or gathering from them. So the ninth reason, and the ninth thing that's actually kind of changed the way we manage these individuals, is the anterior segment conditions that we're managing and monitoring. And there's a lot here, but I'm actually going to show you the most common reasons that we're actually looking at these patients. Now, What you're looking at here is something called a pachymetry scan. And the reason why it's called a pachymetry scan is because it's measuring the central corneal thickness along with the corneal thickness throughout the cornea. See what's cool, and you can see it in the upper left-hand quadrant where you actually see the eye and you see the measurement. Not only is it taking a diagonal measurement, but it's taking measurements all the way around in a radial pattern that centers itself in the center of the pupil all the way around the cornea. So what you get is this remarkable map of information. And on the bottom left-hand side, you can actually see the specific corneal thicknesses and all the quadrants that you're looking at. And on the right-hand side, you're actually seeing a color-coded map that represents the corneal thicknesses in those areas. So what do we use the technology for? Well, let me just show you an example of an individual who's had LASIK surgery. And not surprisingly, they have a thinner cornea centrally than we would expect, and you can actually see that present here. And this is actually important to understand and monitor over time and certainly look at for changes. What else are we looking at with anterior segment OCT? Well, certainly keratoconus, pellucid marginal degeneration, or any of the corneal ectasias. We're actually not only at this point monitoring with corneal topography, but we're also measuring corneal thicknesses. Why? Because we can actually see a corresponding thinning in the exact same area in these individuals where we actually see corneal steepening. What we've also been surprised at is that at times you'll see differences in corneal topographies versus OCT corneal thicknesses. Again, make sure you keep in mind that the left-hand side is literally an imported image from our topographer. The right-hand side is the pachymetry view. The left-hand side, from a topography perspective, you're actually looking at the curvature in the front of the cornea. On the bottom right-hand side, you're actually looking at the OCT pachymetry, which is giving us or identifying the thickness of the cornea. Now, here's the cool part. So what I'm going to do here is I'm actually going to turn the radial scans, and I want you guys all to look at the corneal cross-section on the top right-hand side of the screen. So I'm going to change it once, and when I change it, you can actually see that the profile's actually changed, and you can actually start to see some of the thinning on the left-hand portion of that cornea. And I'm going to slice it, I'm going to turn it once again, and when I do that and run it right through the actual steep zone that you can see just below that in the pachymetry map, you can actually see the difference in profile that exists in the cornea at this point. And you can take that small little arrow and you can turn it all the way around the cornea. And because of that, you can just do things that most anterior OCTs cannot do. Most of them will simply give you one line scan or a few line scans. But this not only gives you the ability to do a line scan, it gives you the ability to do radial scans from a given point, and it gives you the ability to look at the cornea in a way that we've never been able to do before with technology like this. Here's one of the other interesting things that we're seeing too. Those individuals that we're seeing with slightly decreased best-corrected visual acuity that's unexplained, they have some level of irregular astigmatism, but they're not necessarily showing any type of characteristic or classic keratoconic or pellucid changes on the topography. We're actually measuring these individuals and these patients on pachymetry or on anterior segment OCT, and we're seeing thinning in these areas that are corresponding to future areas of steepening in these patients. So we're now catching these individuals sooner. What are we also doing? We're managing our patients with Fuchs endothelial dystrophy differently. If you think about how we used to measure corneal thickness with a ultrasound pachymetry probe, you can understand the challenges that exist with these individuals, in particular if you're not perfectly perpendicular to the cornea, because what will actually happen is if you're measuring the corneal thickness on a slight angle, again, not perfectly perpendicular with the ultrasound probe, you'll actually overestimate the thickness because you're simply not going through the smallest or the shortest area of the cornea. Well, the OCT, the anterior segment scans, and the pachymetry scans in particular are almost user or error proof in that it doesn't matter how you're actually measuring them because you're actually looking at the cornea and the OCT is just simply giving you the scan or giving you the view. So it's not dependent on how perpendicular the probe is actually to the surface of the cornea. So what you see here in the middle, so if you divide this printout into three, you look at the very top row horizontally, the middle row, and the bottom row. The very middle row is the first visit of this patient. The top row is the second time I actually saw this patient. That's actually after we started them on Muro 128. We actually discussed some DMEX surgery, some other options for these individuals, but they really didn't want to pursue surgical options at this time. So we started them on Muro 128 4 times a day. And what you can see in the bottom scan is the actual difference map. So what it's showing me is after a month on Muro 128 4 times a day, you can see that there's some corneal thinning that's actually occurring. Not surprisingly, you're actually seeing some of the corneal thinning occurring, or more so superiorly, which is that portion that's underneath the eyelid, which is just challenged more from hypoxic conditions in those patients with Fuchs endothelial dystrophy. Again, the lid is covering that up. There's more oxygen demands there, so you would expect when you actually put Muro 128 on those corneas that you see more of a response on that superior portion. So now we're going to come to a hidden gem with the OCT technology, and that's with scleral lenses. For those of you who don't fit scleral lenses, I urge you to look and find those individuals in your communities that are fitting scleral lenses and offer this to your patients if they are in need of it. For those of you who aren't fitting scleral lenses but are interested in it, feel free to email me after the discussion or the presentation, because this is an area of remarkable professional satisfaction in the eye care field and the ability to simply change lives. Not only are these contact lenses remarkably comfortable, but they correct these highly irregular corneas. They're based on a principle that's very different than traditional contact lenses, though, because these lenses actually vault the cornea. So they're based on a principle of sagittal depth. Now, what you're actually looking at here is how we used to measure central corneal clearance over our corneas with patients who are wearing scleral lenses. And what you can see on the left-hand side is the contact lens of this optic section. In the middle of the optic section, you can actually see the fluorescein pattern that actually represents the central corneal thickness. And on the right-hand side of the optic section, you can actually see the cornea. So what we used to do, and what we still do as an initial measure, and almost to estimate kind of how poor I am at actually measuring the central corneal thickness, is how thick is that green band of fluorescein with respect to the thickness of the contact lens? And what we do now is, in addition to that, we actually look at these individuals with OCT. So what this is a pachymetry scan on an individual, and the scan is directly horizontal, and what you can see is you can actually get down to the micrometers of clearance. This is important when you're fitting scleral lenses, because we actually need to communicate with our labs to the best of our ability what the actual clearance is over the central cornea. So not only can we give them approximations at this point, we can give them down to the micrometer of clearance. What this also gives us the ability to do is the second lens that we may need to select for this individual, we can do with a high level of assurance that that second lens is likely going to be the one that provides the clearance that we require. It's also important too, because we're constantly striving for anywhere from 100 to 300 micrometers of clearance. So when you look at these individuals, you can actually see how far off we are from this. And from this individual, I just know exactly how many micrometers I need to sink the sagittal depth. So when you're looking at 438 micrometers of clearance, I need to decrease that approximately 200 micrometers to really get it in the sweet spot. Now, what's also important to understand is that, in particular with our keratoconic pits, and all I've done here is literally the top view is taking a scan directly horizontal over the lens and the cornea, and in the bottom picture, what you see is a pachymetry scan on an angle, and you can see that on the kind of the top right-hand portion of the picture. You can see the angle that I took the scan, but you can see where that cone's actually approaching the lens a little bit more closely. I want to make sure that we're still clearing there, and I have the ability to do that. What you can also see too is the settling that occurs with these lenses throughout the day. So on the top picture, you can see the lens clearance after 20 minutes, and after 10 hours, you can actually see the lens clearance that's present as well too. And you can see that there is less clearance towards the end of the day. This is an individual who actually came in to pick up their contact lenses at our office, and there were 2 people that were picking up scleral lenses that day, and unfortunately, the wrong lens was dispensed to this individual. And before I even walked into the exam room, because the anterior segment OCT is actually taken prior to me entering the exam room, I can actually see that the posterior surface of the lens is abutting the cornea, and that's just simply not supposed to be happening. So I immediately checked the lenses, and I knew that we had to switch the lenses on those patients. So our technician graciously walked into the room, room, said, Dr. B wants you to try on another set of lenses, and we did so accordingly, and the next set of lenses fit perfectly. But what this also does is it gives you an idea and perspective of what some of the problems that a patient may be having with scleral lenses as well too. So prior to me entering the exam room, I have this picture, and I have a pachymetry scan, so I can actually look at it anywhere I want to around the cornea. And what you can see here is that the fluid is simply significantly cloudy. So I know that I'm dealing with a clouding situation. So the question now is, because I think we answered two of the three. We answered the first question, which is, what does the scans actually mean, and what's normal versus abnormal? The second was how does it make us or help us make better clinical decisions? The third is, how do we actually make the technology make sense from a dollars and cents perspective? And is it something that it belongs in our practices? Well, this is a code that was eliminated in January of 2011, the 92135, which was coded each time we actually scanned the OCT. And it was replaced with two codes, 92132, which is anterior segment imaging. They added that one, which wasn't available previously. 92133 is a scan of the optic nerve, and 92134 represents either a unilateral or a bilateral scan of the macula or the posterior pole. Now, what's interesting is that in these, each of these codes is billed once, whether or not you actually scan one eye or both eyes. 92132, which is the anterior segment scan, can be billed on the same day as 92133 or 92134, assuming the diagnosis involved with the visit support both of those procedures. But what's important to remember is that the 92133 and 92134 are essentially mutually exclusive, which means if you bill them on the same day, those are codes that will not be both be reimbursed. So you simply pick one or the other, which is usually guided by the primary reason for the patient's visit, and submit that to insurance. Now, for those of you that are kind of following reimbursements and where they are, and for those of you that are American Optometric Association members, there is an awesome tool that's available to you at no cost. It's called AOAcodingtoday.com, and you simply enter your username and your password, which they'll specify on the website how you actually do that. And it'll actually give you all the rules for all of the coding, for all of the evaluation and management codes that we typically use in a day, for all the 9200 codes, and all the procedure codes that we use as well too. But more specifically, it'll give us guidance on the OCT as well too, and when to use those scans and what the local reimbursements are, which is essentially what you're showing here. Just me pulling the local Medicare reimbursements for my area in Northwest Ohio. And what I also wanted to do here was just very, very briefly show you what all of this translates into, and how to actually very, very quickly determine, does this make sense in your office? So what I did was, on the Y, you can see scans per month, and on the X, I did scans per day. So if you just looked at the last 3 or 4 or 5 days of patient care, you could probably look through your files and determine individuals or people that would likely benefit from an OCT scan. And you just simply count up how many per day you actually had. And then you can determine very, very quickly how many scans per month using a 20 doctor day per month work schedule. And what you can see here is very easy calculation. If you have 1 scan per day, you get 20 scans per month. If you think you're averaging 2 scans per day, you'll get 40 scans per month. What I can tell you is that from personal perspective, whatever you think you'll be using or scanning it, double that number, because once you get it, you'll realize what you'll actually start using it for, and a lot of the alternative things or other things that you'll just start using the scans for. And what I really did here was I monetized it. So again, looking at the previous graph, if you look at the scans per day, if you were, for example, at 1 scan per day, you literally cover an OptoView or a payment for an OCT. If you did 2 scans per day, you'd actually double that, and you'd be generating significant revenue, and so on, and so on, and so on. One of the things that's interesting with investing in technologies like this, in particular if you're in a single doctor practice, is most of us know at this point that this has really become the standard of care in managing our individuals and managing our patients. But we always get concerned about, will we actually be able to generate the dollars or the revenue to actually financially support the system? And what you can see is that it's remarkably easy to do. And for those of you that are fortunate enough to be in multiple doc practices, you're really looking at cutting the cost of the technology in half, and also the ability to even maximize further than what we discussed the utilization of the technology as well. So again, I hope I've added clarity to those three topics that I wanted to address. And at this point, I think I'm going to start answering some questions here. And it looks like, wow, okay, we have a lot. So Christina and Mike, I'm going to ask the two of you, because it looks like they're listed here. I'm going to start answering questions, and as soon as you guys think I should stop, and I'll kind of start asking you guys when I should stop, you just tell me to. Okay, so a clinician asked, I want to increase my OCT analysis skills. Is there a text or a website you can recommend? Yeah, absolutely. Actually, OptoView is going to be launching what I think is called OptoView Academy relatively soon here. And what that'll give you the ability to do is, as a guide, it'll give you the ability to literally look up a lot of the stuff and the things that we talked about on both kind of the basics of OCT, because a lot of times, again, we jump to the pathologies and then we say, wait a second, what are we really looking at here? So it'll give you some of those basics. It'll also give you some of those real-world cases and what you're actually doing under those circumstances. I know that this was a really kind of quick, large overview on how we're utilizing it, but each one of those cases that I talked to you about has real management that's associated with it that's been enhanced through OCT. So it'll talk through each of those cases and some of those examples as well, too. It'll actually provide a forum as well, too, to talk to other clinicians that are utilizing OCTs as well. Okay, we got another question here. How acceptable is it to do pachymetry on OCT for glaucoma and bill it, or do you have to have a separate pachymeter equipment to do so? So this is a great question, and the reason why I say that is because there's oftentimes confusion, and I think part of the confusion lies in the name of the scan that's given on this OCT. So the name of the scan on the OCT is called the pachymetry scan. But the pachymetry scan is actually, and technically speaking, an anterior segment scan on your OCT. So for the purposes of anterior segment OCT, whenever you're utilizing either the pachymetry scan or any of the angle measurements that you can use for your glaucoma patients, think of using the 92132 code as opposed to the 76514 code, which is the code we used when we utilized ultrasound pachymetry. I hope that clears that up, and again, if there is further questions on that, feel free to email me after. Okay, so there's another question here. What would be a good pearl for differentiating optic disc swelling from buried drusen of the optic disc? Oh, this is this is another good one, and this is one that you learn a lot about when you actually start scanning these swollen discs, because you'll actually see the drusen actually having a very almost characteristic appearance, and it'll actually look almost like a darker area. The way you actually see it the best is with the grayscale scan, and that's the way that you can actually identify those as easiest. So when you scan the optic nerve head, there's really several different scans, but you really want the one scan that will give you the three-dimensional view, or the three-dimensional perspective on that optic nerve head. And again, you'll see kind of almost this large white druze that's actually present in the nerve heads of these patients or individuals. And certainly if there's any doubt, you really do need to work up this patient to rule out papilledema. But again, you can see it relatively well on those OCT scans. Okay, what is the significance of a small annular yellow or red pattern or claw pattern on the ganglion cell complex normal database significance map? You know, I don't know if I'm following or I'm understanding this question. So if the person that actually typed that question in, I see your name here, if you want to retype that question just to give me a little bit more perspective on what you're looking at, I'm not sure I'm following the question there, and then I'll come back to that one. In the meantime, I'll read the next one here. Plaquenil patient as seen on example OCT. Would that level of toxicity be found with traditional exam, and would this level of toxicity warrant change of medical management? So to answer your question, no, it typically wouldn't be found on physical inspection, and it wouldn't even be found on on visual field testing, and that's actually the challenge with it. It would require a letter back to the rheumatologist that's actually managing this individual to let them know that there is toxicity to the retina. So we certainly wouldn't be making the management calls on that. The actual rheumatologist would be. But yeah, that would warrant communication with the rheumatologist saying that there has in fact been a change in the retina secondary to Plaquenil use. Okay. Would OCT be beneficial for reverse geometry lens fits? You know, that's an interesting question. To answer that the best that I can, I don't know yet. I'm still actually learning how to interpret those scans because on some individuals, in particular our ortho K, you can actually see a little bit of that space at the reverse curve. But the challenge is for me when we're looking at an OCT scan is I'm not really sure how that's making me make better decisions with my patients, if that makes sense. So I don't know if there's truly a benefit to reverse geometry lens fits and OCT scans. Okay, so there are questions coming in like crazy here. All right, keep going here. Is Medicare paying for OCD on age-related macular degeneration patients? How often are they allowing these? So to answer your question, Medicare is offering payment on AMD patients. Saying that, I'm going to answer the second part of the question indirectly. I'm not a billing and coding expert. I like to consider myself staying, relatively speaking, on top of the latest rules. I am pretty sure that Medicare will actually reimburse up to every 28 days in a medically necessary case of macular scans. I obviously don't see macular degeneration as being medically necessary scans every 28 days. We've never had issues being reimbursed with Medicare on AMD patients, but saying that the most frequent and aggressive schedule we have with scanning AMD patients are those individuals with those larger, softer drusen and those individuals with a high genetic risk towards developing wet AMD. Those are just the patients that we're monitoring closest. Those are the minority as opposed to the majority of individuals, but we've been monitoring those, again, significantly more closely, and we scan those individuals about every 3 months. I hope that gives just a little bit of perspective on that question. Okay, so there is a question here. What steps to ensure your nerves and retinal scans are valid? So here's the good thing, and for this question, I'm assuming that I'm going to answer it from a non-user's question, so somebody who's interested in purchasing the technology. How do you make sure the scans are valid? There are actually numbers that are posted in the top portion of the scans that actually tell you whether or not the scan's good, marginal, or it's a weak scan. And as long as that number is green, in the green zone, you're actually fairly confident that you have a good scan. What's interesting with the eye view is and it drives very, very differently. So, for example, if you're a current time domain user and you're thinking about updating to the iView, it's a completely different system. It's so easy to use. Almost day one, the technicians in our office that were actually trained to use it were literally taking expert-grade OCT scans, because what OptoView's done, interestingly, is based on the software capture system. They're trying to always pull away more and more and more of the variability that exists with the user actually capturing that image. And then with the eye scan, it's just like it's the next step. So to put things into perspective, the eye scan is actually the box that houses everything. So it's not the one that's driven by a joystick. It's actually the one where the patient puts their head inside or lays it on the front of the unit. and the unit literally talks to the patient. The voice is, mind you, a little bit creepy, but it's remarkably effective. I mean, this thing does everything it's supposed to do. And what's even remarkable as well, too, it's doing it through undilated pupils with its wellness scan. So it just has this remarkable ability to capture these images. For those that are current iView users, what you really want to make sure you're doing is having the patient fixate appropriately and where they're supposed to be fixating. One of the challenges we sometimes have are individuals with severe macular degeneration or a lot of macular scarring where they don't have a lot of fixation, or they may be severe macular degeneration and glaucoma patients and they don't have a lot of fixation, and we're trying to get optic nerve scans. So what you really need to do there is just simply leverage kind of outside tools around and make sure you're moving their fixation points so they in fact are, or you're imaging the proper or the appropriate tissues at that point. Okay.
Okay. We are actually now at the end of our scheduled time. So I'd like to thank everyone for joining us this evening. And if you'd like more information on an OptiView OCT, or you'd like to have somebody answer one of the questions that didn't get answered tonight, please email us. The email address is info@optiview.com, and we'll put you in contact with the right person to either answer your question or get you more information. So thank you so much for your time this evening, and have a great night.
Thanks, everybody.